Hello, my name is Dr. Rodrigo Astolfi and I'm from Federal University of Ceará. I'm going to talk about minimally invasive calcaneus osteotomy. More specifically, I'm going to talk about minimally invasive calcaneus osteotomy in osteoporotic bone with immediate weight bearing. I have no conflicts of interest for this lecture. We understand that immediate weight bearing is fundamental for elderly people for a good recovery, and we think this is the next frontier for our specialty. But we had some problems before. In flat foot correction in osteoporotic bone, sometimes we were able to do the varus correction, but sometimes we got some loosening in the lateral view with the upper migration of the distal fragment. In cavus foot correction, we were able to correct the lateral view, but in some osteoporotic bone, we had some medial collapse worsening the varus of the cavus foot. So what can you do to avoid that? This is our experience for flat foot correction in osteoporotic bone. We operate the patient in ventral position. We understand that it's easier to do the nerve block. It's easy to see the lateral view of the calcaneus. You don't need to secure the patient on the table, so it's faster to position the patient. It's also very easy to see the axial view of the calcaneus. We do a stretching of the gastrocnemius. Pass a K-wire subcutaneously so it can guide the safe zone of your osteotomy. We do a straight cut of the calcaneus. Through the same portal you made the cut, we start the leverage. The first leverage intends to varus the calcaneus. You should do as much as you can. It's easy to regret not correcting enough the flat foot. With the ventral position, it's easy to see the Harris view, so you can have the medial, the parameter, which is the sustentaculo lutare parameter to the axial view. It's easy to pass this to see the correction. We understand that it's important to rotate the distal fragment and put it under the proximal fragment. When you don't do that, the ground force tends to deform your correction, to make the dorsal migration of the distal fragment. If you're able to rotate it, probably the ground force will help you compressing the fragment, because you are talking about immediate weight bearing. So having this little step in between the fragments, we understand it's important, and you have a immediate weight bearing with no problems. To do that, it's important to do a accessory portal just lateral to the Achilles tendon. We secure two leverages at the same time. One leverage intends to make the varus, and another leverage intends to flex the calcaneus. I can hold it, the both leverage with one hand and pass the screws with the other hand. You should pass the plantar screw first, so it can help you flex and higher the pitch of the calcaneus. This is the correction with 6 weeks. After the calcaneus correction, we made a soft tissue advance of the tibialis posterior. It's easy to insert an anchor at the navicular, still in ventral position, and advancing the tibialis posterior into the anchor into the navicular. This is the aspect of some cases. It's very good to the correction. And we have already published these results before. We will be glad if you take a look at it. Some technical tips about cavus foot correction in osteoporotic bone. We still operate in ventral position. Maybe use two K-wires so you can know the amount of cortical bone, of lateral cortical bone you're going to remove. This is a Dwyer osteotomy. But we know in cavus foot it's difficult to correct severe deformities. we understand that the best osteotomy to correct the varus is the lateral sliding, but you may have some problems with the neurovascular bundle. So we do a Zadek osteotomy. It may be relaxing, maybe it relaxes the medial retinaculum and allows you to do some lateral sliding. So our osteotomy is lateral sliding, dorsal flexing the calcaneus, and lateral flexing the calcaneus, which is a Zadek with Dwyer and lateral sliding. This is a very powerful correction. We understand the lateral sliding is very important, so we do an accessory point just medial to the calcaneus, bridge the calcaneus to the lateral. It makes it easier to lateral slide. And we understand the lateral sliding is important with in osteoporotic bone to help the medial collapse of the calcaneus. If you lateral slide, it will not medial collapse, even in osteoporotic bone with immediate weight bearing. This is some of our results, very powerful correction. We have published these results before, we can take a look at that. To take home ideas, we understand that rotate the distal fragment in flat foot correction and put it under the proximal fragment is fundamental. Maybe you need to look about this step between the fragments. Use accessory portals and hold them at the same time so you can varus and flex as much as you can. Use the plantar screw first. Ventral position, I think it's important and much easier to see the correction. In cavus foot correction, also ventral positioning. Zadek osteotomy allows you some lateral slide. In lateral slide avoids varus collapse in cavus foot with osteoporotic bone. Thank you very much.